Hello, this is Dr. Catherine Godwin. I'm the medical director of the adult program for eating disorders here at Laureate. And we are putting together our Family Week talks, which are usually held in person in a convenient format for virtual viewing, both just because right now is a good time to do that and because family members who cannot come to Family Week can hopefully access these and benefit from the program as well. I'll be going through two different talks. This talk is the psychiatric considerations in the treatment of eating disorders, and then there's going to be a separate talk, which is the medical considerations in the treatment of eating disorders. Because the brain lives in the physical body, there's going to be some crossover between the two of them. And I'll just tell you, there's no post-test. These are just talks for your information and to gather what you wish from them. And sometimes watching more than once can be helpful too, if you have the time. All right, we'll get started. Oh, maybe we'll get started. There we go. So there's my contact information. I'm providing my email address because that is the best way to reach me. Not very accessible by phone during the workday, but the email address is very accessible. All right, we're going to talk about several psychiatric comorbidities. Comorbidity is just a fancy term for it exists at the same time as the eating disorder. So in this case, every person would have an eating disorder plus depression or plus bipolar disorder. And most of these are very common in the general society. But the reason that we pick out our top ones include that about 2/3 of patients who have anxiety or depression or both, that's about 2/3 of patients with eating disorders have anxiety or depression or both. And of that 2/3, about 50% of them, about half of them, had their anxiety or depression before the onset of their eating disorder, and about half of them had depression or anxiety after the onset of their eating disorder. Where that can become pertinent is if somebody didn't develop anxiety or depression until they were in a malnourished state, that may give us some indications regarding how their brain chemistry is impacted by malnutrition and brings out an illness that hadn't previously been present. Whereas if the anxiety or depression had been present before the onset of their eating disorder, almost certainly the mood or anxiety disorder contributed to the stress that was the context in which the eating disorder developed, and regardless of a malnourished state at that time. Obsessive compulsive disorder is present in about 40% of patients who also have eating disorder. And to make a diagnosis of obsessive compulsive disorder, somebody has to meet full criteria for OCD outside of the criteria they would meet from their eating disorder. And that's important because a lot of patients' eating disorders line up in a way that looks like obsessive compulsive disorder and have very similar brain pathways and very similar responses to treatment. But we only diagnose the OCD in addition to the eating disorder in about 40% of patients, because for many of our patients, their OCD traits get moved over to just however the eating disorder expresses the OCD traits. Being aware of the comorbidity of both existing at the same time allows us, though, to better focus on the skills and possibly medication treatments that we know are helpful in OCD as well. Post-traumatic stress disorder is the PTSD there, and 30 to 60% of patients who have an eating disorder are also diagnosed with PTSD. And 25% of patients who have a drug or alcohol or who have an eating disorder also could be diagnosed with a drug or alcohol concern. And that's probably about the same lifetime prevalence over the general population, but the way that drugs and alcohol are abused in the eating disorder may be very different. Okay, so you've just heard the word disorder several times, and we'll talk for a moment about what a symptom is, a psychiatric symptom versus a disorder. For all psychiatric symptoms, there's a threshold or a level at which the symptoms become clustered together and severe enough to reach the level that we consider a diagnosis of a disorder. So somebody can have sadness or feel depressed, but not have major depressive disorder. But if they have the right symptoms all together at the same time, existing over longer periods of time rather than just briefly, and at a certain level of severity, then it becomes a major depressive disorder as opposed to depressive symptoms or sadness. A lot of psychiatric terms are being used in our common vernacular nowadays, and so there can be a lot of confusion in describing what somebody is experiencing as their internal experience or how family members are perceiving their experience. And so psychiatrists, myself included, may ask a lot of questions like, when you say anxiety, what are you describing? And the reason for that is that some people will say anxiety and just be describing a physical sensation, and some people will say anxiety may be describing a very busy mind state, or maybe a ruminative state where they're thinking the same small category of ideas but over and over and over again. So a psychiatrist in their diagnostic process with the patient will tend to ask a lot of clarifying questions. At this time, all psychiatric diagnoses are based on a clinical interview and the history that the patient and her family can tell us. So unfortunately, we cannot just do a brain scan or a lab test and know which kind of psychiatric illness we're coping with. There are more than 400 individual genes that are associated with the development of major depressive disorder. It is a very diverse illness within the body and has multiple components that are both genetic or inherited and components that are more from experiences in life and stressors and the learning of coping skills and of confidence in the individual self that are protective. And that combination of all these different things can come together to whether an individual develops a psychiatric diagnosis. And so that may be part of the history taking. Also, family members provide a lot of important history. Just like in any two-person conversation, one person may perceive something in one way and another person perceives that exact same discussion in a different way. And this is a very common human interaction between spouses, between friends, between moms and dads with their children, and vice versa. So very common interaction. And there's validity to both the patient's experience and to her family member's experience. And we want to take all of that information into context. Okay. So we're going to go from overview to specific syndromes now. And depression is something that most people can recognize pretty well. And that is partly because it is so prominent in our society. We know that depression is strongly genetically linked. And the symptoms that go along with depression include sadness or irritability. The distinction there is that in young people, irritability may be the more prominent symptom of a major depressive disorder versus specifically sadness. So sometimes it can get kind of missed or be confusing because you're seeing an irritable presentation, but it still is the illness of depression. Sadness is more commonly identified in what most people will think of when they think of depression. Along with that goes a decrease in motivation or interest or pleasure. And those are three different categories, but decreases in all three of them or one or two of them. So maybe you're not as motivated or interested for activities or hobbies or groups that you normally really enjoy, and your interests fall off. Maybe if you go ahead and do whatever group or club you belong to or sport you belong to, you recognize that you do not enjoy it the way that you enjoyed it before the onset of the depression. Changes in sleep and changes in appetite are also part of depression. And there we are saying changes because sleep needs or sleep ability and appetite can go up or down in the course of a major depressive disorder. Typically, if a person is having very low energy, they may also have an increase in appetite, but that person with the same very low energy may instead have a decrease in appetite, including possibly nausea. Somebody who is not able to sleep as well may be activated and anxious and irritable, and that more commonly goes along with a decrease in appetite or a more chaotic pattern. Possibly people with depression could experience suicidal thoughts. We'll talk more about suicidal thoughts as a separate category, but it's important to know that not every person who has depression experiences suicidal thinking. Certainly not every person who has depression is going to be individually at risk of suicidal action if that's not part of their presentation, but suicidal thoughts can commonly occur with depression. Most often, suicidal thoughts will also occur for someone who's very overwhelmed or very hopeless, overstimulated. And those are areas where we can assess and intervene with suicidal thinking, even while the depression is still present, or anxiety or whatever is contributing to the sense of being overwhelmed. To go forward with the diagnosis of depression, to meet criteria for major depressive disorder, those symptoms from the last slide need to be present about 50% of the time over about 2 weeks. So this is the criteria for moving from symptoms of an illness into a full categorization as having a depressive disorder. For a lot of people, their syndrome of depression may last much longer than 2 weeks. So sometimes people will be saying that their depression has been ongoing for several years. Sometimes what's being described there is that depression has been their primary state for the last several years, with periods of some improvement in between episodes of depression, and sometimes somebody is describing continuous depression. The symptoms, again, that are listed on the previous slide also need to be present in a variety of circumstances. So present at work, present at home, present at church, present socially. If symptoms are only present in a distinct circumstance, like just at school or just at work or just with a significant relationship, then that signals that there may be something that's dysfunctional or malfunctioning within that other context, and isn't depression as an illness, but more depression as a response to a specific stressor. Additionally, depression to be diagnosed requires that there is dysfunction in relationships and dysfunction in normal performance for that person in the context of the illness. So in the time period that they've been suffering depressive symptoms, they're no longer functioning in their relationships as well as before, or in their work or school performance. Okay. The primary treatment for major depressive disorder is SSRIs, SNRIs. These are very common phrases, and then there's a variety of other antidepressant medications. What the variety of medications do typically is they provide your brain to use the serotonin your brain is already producing and have it act longer. They do not give the brain serotonin, and other ones don't give the brain norepinephrine or dopamine. They are signaling the brain for the serotonin or other chemicals that it's releasing on its own to just act longer, which tells the brain that you have more of that chemical than you really do. And that may help bring somebody back to a more neutral or more positive brain chemistry. If somebody is malnourished, their serotonin supplies may be depleted, and that makes medication less effective. We'll talk at the beginning of the medical slide more about that depletion of neurochemicals, but that treatment system is going to be important through all of the primary psychiatric disorders as we talk through them. So nutrition is very important to successful treatment of the variety of psychiatric disorders, and it's very important to recognize that the person becoming malnourished was part of their development of the illness, because again, the effect that nutrition can have on brain chemistry. Okay. Going on to bipolar disorder. Bipolar disorder is not more common in patients with eating disorder than it is in a patient without eating disorder. It has the same prevalence as it does in the general population, but it's important to recognize if it's present. In bipolar disorder, the person typically will experience the same symptoms as major depressive disorder that we just described, but they'll also have periods of mania or hypomania that typically last about 7 days in length, or if the person required hospitalization for the elevated mood state. So I use this googly guy here on your screen to be an example of what mania might look like. And then hypomania is a less extreme level of the same symptoms. They're on the next slide. It should not go unnoticed, and typically family members are better at reporting if mania is occurring for somebody than the patient themselves, because mania and hypomania are generally a positive state to the person experiencing them, and they may have difficulty recognizing these as symptoms that need to be reported or discussed when they're considering their medication options. There can also be mixed states where a patient is having depressive symptoms and manic symptoms all at the same time. That is more unpleasant to the person experiencing it. And mixed states of bipolar disorder may be associated with a higher risk of having suicidal action because the person still has very depressive thoughts and feelings with an energy level that is increased and agitated and hard to contain. So mania in its more pure form includes symptoms of not needing as much sleep, but having your usual or improved energy, having thoughts race more than usual, increases in impulsivity and self-gratification. So the things that people do that are impulsive or reckless are also because it feels positive to the person. They may also have a general sense of well-being in their belief that risks that they take will turn out well. So greatly under-evaluating risk and greatly over-evaluating reward. And then physical restlessness may be part of that presentation. So somebody who is in a manic state may be at higher risk of driving their car too fast, using drugs or alcohol they would not normally use, engaging in relationships that are outside their usual values, various things along that line. If the mania is brought on by substance abuse, so somebody is using a substance that causes an elevated mood state, then that is not necessarily bipolar disorder. That is a substance intoxication. But because people with bipolar disorder are at higher risk of abusing substances, that can be difficult to figure out. The reason why mania is so important for us to differentiate from somebody who has the depressive but not the manic state is that treatment for bipolar disorder is very different than treatment for depressive disorder. And if somebody who has a bipolar disorder is treated as though they only have depression, that may cause their mood symptoms to become more extreme or more unstable and possibly place them at higher risk. Bipolar disorder is also highly genetic, so family history is important for this diagnosis as well. We're going to move on from the mood disorders of major depressive disorder and bipolar disorder and move into the anxiety disorders. To some degrees, this is a false separation. Most people who have depressive symptoms also have some degree of anxious symptoms. Most people with anxiety disorders also have some symptoms that are depressive in nature. But regarding helping us organize a person's symptom occurrence in a way that allows us to better target their treatment, we try to separate out those different disorders, including by which one occurred first, which one occurred later, was anything in response to a specific stressor, and onward from there. So under the anxiety disorders, I've got several listed: panic disorder, social anxiety disorder, and generalized anxiety disorder. We'll cover PTSD and OCD separately. I want to start by mentioning that panic itself is not a disorder. We all naturally, spontaneously should experience panic in a highly distressing situation. So panic can occur outside of psychiatric illness, but just within the normal experience. A panic attack itself is discrete, meaning that there's a beginning to it and an end to it, typically lasting 5 to 15 minutes, usually brought on by a stressor, and that stressor could be various things. Back when we were developing and living in caves, a lion attacking you or a mammoth or what have you would be a good reason to panic. And your body would want to utilize the adrenaline of the panic attack to help you defend yourself. So in that way, panic is adaptive. In today's world, there are not as many attacks by lions or mammoths. So what might feel like an attack to our systems could include taking a really difficult exam, having a job interview, public speaking. Lots of different situations can cause somebody to have a panic attack. And again, most of them last 5 to 15 minutes. They do have a discrete ending. Nobody's ever died from a panic attack, but it feels really distressing to the person who's experiencing it. Panic disorder includes having the panic attacks, but having them in a pattern or intensity that causes the person to change their behaviors due to fear of having more panic attacks. In panic disorder, somebody who previously had success in certain areas may step back from their usual life engagement. That could be stage performance or music performance. It could be public speaking. It could be debate. It could be sports, whatever, or socialization. But the person steps back from what they normally and previously have enjoyed because they've learned that they may have a panic attack, and feeling that out of control and that uncomfortable in front of other people is even more terrifying than feeling that way on your own. So people with panic disorder tend to begin to isolate themselves from their usual activities. And panic attacks can also occur in the context of panic disorder. So not somebody who just has a panic attack, but somebody who has the illness. Out of the blue, they don't have to be triggered by something. And sometimes panic attacks even occur during sleep, not responsive to nightmares, because that's been studied. Taking somebody who has frequent nighttime panic attacks, looking at their sleep pattern and finding that they're having panic attacks when they're not even in REM sleep, which is the dreaming part of sleep. Those studies have also shown us that patients with panic disorder could have a change in their respiratory system about 40 minutes before the panic attack actually hits, which lets us know that this is a physiologic disorder that is not an overreaction to a stressor in the moment, but is something that is more in depth for the person who has the panic disorder. The methods of treating panic disorder: the very best treatment is talk therapy. Usually talk therapy with a focus on exposures, where you do something that tends to be a fear or anxiety provoking episode for you, and you utilize skill sets that you've been working on in therapy to help self-regulate the physical symptoms and the thought symptoms of panic, so that you become more and more effective in recognizing when a panic attack is likely to happen or getting started, and then using your skill sets to help reduce the intensity or the length of those individual panic attacks. For a lot of people, learning that self-efficacy can really diminish the panic disorder and have it very much improve over time. Additionally, some patients with panic disorder may benefit from the treatment with medications, including the antidepressant medications. So antidepressant medications are a little bit misnamed, that they're called antidepressant, but they're also generally FDA approved for the treatment of generalized anxiety disorder or social anxiety disorder or panic disorder or OCD or PTSD. So these medications that we call antidepressants actually hit or treat multiple anxiety disorders and major depression. So sometimes it's less confusing just to call them according to their chemical action as an SSRI or an SNRI. But in either case, the SSRIs and the SNRIs are the primary start of medication treatment for somebody with panic disorder. Sometimes a patient with panic disorder will, instead of getting an SSRI or an SNRI, or instead of doing therapy, they will receive treatment with benzodiazepines. Benzodiazepines are medications like Xanax, Valium, Ativan, Klonopin, and of course their generic names as well. And those medications hit GABA receptors. GABA receptors in the brain are the same receptors that alcohol hits. And therein lies the difficulty with using the benzodiazepine class of medication in the treatment of any of the anxiety disorders. By hitting that receptor, it is suppressing the symptom of anxiety in the moment, but it can build up tolerance where the person has to take larger and larger doses over time to still get benefit from it. And they can develop physical dependence where if the person doesn't have their medication, They may then go into physical withdrawal, again, just like alcohol can go into physical withdrawal. So that class of medications is really overprescribed for the anxiety disorders and doesn't tend to lead to a long-term improvement in the diagnosis for any of these anxiety disorders, but rather is kind of a stopgap, during which time, if they are needed, they can also be working on therapy and starting another medication that's going to help longer, more over time. So benzodiazepines, the anti-anxiety class of medications, do have some indications for being helpful for some people for short periods of time, but for the vast majority of people should not be considered as a long-term option, and certainly not as a first-line option for anxiety disorders. Both depressive and anxiety disorders are shown to respond very well if somebody's having mild difficulty to talk therapy. Better actually to talk therapy than to medication therapy. And then somebody who's having a moderate experience of depression or anxiety will tend to respond equally well to medications or to talk therapy, but better to them both used in combination. And somebody with severe or extreme symptoms of depression or anxiety will tend to respond best to medications first, and then the addition of talk therapy. And the reason for that is that when somebody's having a severe or extreme experience of depression or anxiety, their symptoms are so severe that it makes it difficult to engage in and benefit from talk therapy the way that somebody will be able to as the intensity of their illness comes down just a little bit with the benefit of medications. We'll move on now to social anxiety disorder, which is what SAD is here. SAD can stand for a couple of other things in psychiatry, but in this context, we're saying social anxiety disorder. It's just what it sounds like. It's predominantly around social situations or performance situations. And we can all experience some degree of anxiety in those types of situations, but in somebody with the anxiety disorder, it pairs with an avoidance of that feared situation, and sometimes to the degree that the person is going to have trouble meeting goals or milestones in their work or in their academics or other performance situations, because they're so avoidant of having that intense anxiety response. So social anxiety can be very dysfunctional. When somebody has social anxiety in combination with eating disorders, there are a couple of additional concerns we want to think through. One is that patients with eating disorders sometimes will stop wanting to eat in front of other people. And for somebody with social anxiety disorder who doesn't have eating disorder, they may be having intrusive thoughts that they're being seen negatively or that people are overly criticizing them, able to see their faults as the person sees their faults. In eating disorder with social anxiety disorder, that fear that somebody's going to be seeing them eat their food, be critical of them eating their food, have judgment about their food, can all be complicated within that combination of disorders. Also, body image, being out in public may then become a more extreme distress based off of whether body image interacts with being seen in public or being seen by friends and family. So social anxiety symptoms can exist before the eating disorder and contribute to the development of the eating disorder. Or somebody could have the eating disorder and in the context of the eating disorder, develop symptoms of social anxiety. Next, generalized anxiety disorder. Generalized anxiety disorder is to some degree making a mountain out of a molehill. Somebody with generalized anxiety disorder will worry most of the time about a large variety of things. That intensity of worry gets in the way, not only in that the person experiences the distress of their worry, but sometimes the person cannot then make needed decisions because they're overwhelmed with the options of, if they make decision A, what will happen? If they make decision B, what will happen? So what if they make the wrong decision or wrong choice? Somebody with generalized anxiety disorder may seek out friends or trusted family or others to help them in decision making because they don't trust their own judgment, and so they may start making judgments by committee, trying to get other people to weigh in with their feelings to help them move on from that paralyzed state. And then still others with anxiety may seek that reassurance or seek that advice and even then not be able to act on it because they are still uncertain and are fearful of making a wrong decision. So social anxiety and generalized anxiety both respond to SSRIs, the antidepressant class that is the selective serotonin reuptake inhibitor, as well as SNRIs. The same things that I said about panic disorder and benzodiazepines apply to both of these disorders as well. The talk therapy for these disorders is actually very similar to some of the therapy that we do in eating disorders treatment. Going into a fearful situation and social anxiety, so being out in public or doing a performance situation, or in generalized anxiety disorder, having to work through certain areas of decision making. So going into that exposure, tolerating the difficulty of the emotional distress they're experiencing, and then basically living through it without using unhealthy behaviors. Unhealthy behaviors in this case might be avoidance or stopping the exposure early. Could also be feeling out of control of their anxiety, and instead they need to utilize some symptoms or some skills to better manage their symptoms. But teaching somebody who has anxiety, which is a very avoidant feeling of disorder, teaching them to be more empowered in their disorder and to recognize that though they are having intense and uncomfortable feelings, they can move through it successfully and without their feared thing happening. That's very empowering, and that's a big part of treatment for these psychiatric disorders. Very similarly, we move through treatment with exposures in eating disorder care, and we'll talk more about that parallel as we get to OCD, which is conveniently the next slide. So in OCD, we have obsessions. Obsessions are recurrent, persistent, and intrusive thoughts. They can also be worries or images as opposed to specific thought patterns. Some people have intrusive, recurrent images pop into their mind again and again. These obsessions create distress for the person who's experiencing them. And in response to the distress and to try to improve that distress, they then might develop compulsions. Compulsions are the repeated behaviors that are aimed at preventing or reducing the distress. Sometimes they make sense. So this little green blobby guy, if we call that a germ, then that's our obsession, our worry. Then our compulsion might be somewhere within that cleaning bucket, that we need to address that germ fear by cleaning. Now that's a healthy and adaptive behavior outside of OCD, but within OCD, the person might develop a behavior of wiping the counter surface to get it clean. And then they feel satisfied and relieved, and the OCD goes, that feels better. But the intrusive thought returns because it's recurrent and persistent, and it says, did you really wipe the counter well enough? Okay, so the person goes back and wipes the counter again. And wiping it the second time goes, that feels better. But then the obsession comes back. And the person then says, well, wiping the counter isn't helpful enough. I need to go get, instead of this spray cleaner that I'm using, I'm going to go get straight bleach, or I'm going to go get something more powerful or stronger. Maybe I'm going to leave it on the surface for a longer period of time or scrub harder. And the person continues to work and refine their attempts to calm the obsessional worry. But then the obsessional worry just keeps coming back. People will develop rule sets around the compulsions. I have to do this so many times. I have to do this in just this manner. I have to use just this product. And at some point it provides relief for them, which trains the brain, okay, that was a good thing to do. And then at some point the obsession comes back. And so we do the good thing that worked before and we add to it. So OCD is a very looping illness. To continue with the diagnosis of OCD, most people have to experience their OCD behaviors and thoughts over approximately 3 hours a day. You all don't have to leave this talk and become diagnosticians, so I won't go into the ins and outs of all of that, but it really takes up a great deal of time, and for some people it can take all day. Now, if your OCD is about germs and then you're cleaning, that's the example we just did. If your OCD is about food or body image, then the compulsive response may occur in the context of eating disorder behaviors. that are meant to reduce the distress. So if somebody has a fear around a food exposure or a body exposure, they may problem solve that with a technique that becomes part of their eating disorder. It could be restriction, it could be exercise, it could be any of the various eating disorder behaviors meant to target and focus on that fear. And initially, the person feels relief when they use their behavior, but then the fear comes back. And so they have to do the behavior again and develop new rules and new rule sets to keep that fear more at bay. And it becomes obsessive, and it becomes something that the person's not able to do. They can't get to a point where that fear stops occurring, because by its very definition, it's obsessive. So in eating disorder, as an OCD, our treatment is exposure. And formally, this diagnosis is called exposure response prevention, or ERP. It's the most validated form of treatment for people with OCD, and we recognize that what we do each and every day in the treatment setting is exposure response prevention as well, or it certainly can be shifted to take on that more full meaning. So in exposure response prevention for OCD, you might have somebody feel that a surface is contaminated, and then they would go to use their usual obsessive compulsive behavior for it. But in exposure response prevention, we're not going to use the behavior of washing it or cleaning it. We're going to sit here and we're going to tolerate our fear that that surface might be contaminated. And that fear may build and build and eventually peak. And it's going to sometime come off that peak and come back down. The person, having lived through it and having not had a bad thing happen, their feared result happen, even though they haven't done their compulsion to fix it, that's a learning experience, including learning within the chemical structure of the brain. So each time that the person does that exposure, and each time that they don't use the behavior, the compulsion, to fix it for them, their brain learns, okay, that wasn't as bad, or I lived through it, or this is not as fearful as I otherwise think. So they develop increasing insight and tolerance, and the intensity of their anxiety begins to come down, and the length of their anxiety begins to come down. And maybe later they can add another exposure. That now that they've learned this improved brain pathway regarding this particular exposure, now they can pick another one of their obsessive worries and the behaviors they do in result of that, and work the same magic on that obsessive behavior. So in eating disorders, we're doing exposure all day long. We're doing it with every food exposure, and we're doing it with body image exposures as they go throughout their treatment day. And then we'll also talk about the thoughts that are occurring for somebody and how to oppose and tolerate those thoughts. So it shows up all throughout the treatment day. So our women who are here in treatment with us are all working really hard and doing very difficult work. It's very important, though, that as you're doing the exposure response prevention, that you are having more successful moments rather than times of sliding back to using behavior. Because every time that you do the feared thing and you don't use the eating disorder behavior, but either use a positive coping mechanism, a healthy one, or just sit through and tolerate it without using any specific behavior, every time that you do that, your brain is learning, okay, I don't need that behavior. I can be okay without that behavior. But then each time that you do whatever it is, the restriction or a food behavior at the table, eating something in a certain order, going for a run, purging, whatever that other behavior is to fix your distress, then that tells yourself, oh no, that thing was really horrible. If I didn't fix it, it was going to hurt me or kill me, or I'd be damaged in some way, and I had to do my compulsive behavior. And then the compulsive behavior is more cemented or more fixed because it fixed it for a period of time, and it certainly felt better than sitting through it. So when somebody is engaged in therapy, each time that they use their target behavior as their unhealthy coping strategy for fears, they're undoing all those other times that they really went through it and received support and had a successful encounter with that fear. So one of the really important reasons why we work very hard on helping our patients not use behaviors while they're here, even though that is very difficult for them and sometimes for staff, but very difficult for them. And if we know that if it's hard for staff, then it was very hard for family and loved ones before they came in. By using that support and by not using the behavior, the person will have more success and sooner success, not just in the realization of the benefit of this treatment, but also in the brain chemistry and structure itself, that the brain learns from and rebuilds connections based off of these exposures. Okay. So that's OCD, and I could go on and on with that for a while because, again, it is so prominent in our patients who also have eating disorders. But we're going to go on to PTSD, post-traumatic stress disorder. Obviously, by its own name, it's defining that this stress disorder occurs after a trauma. The idea of what is trauma has greatly changed over time. When PTSD was first described, it was described as shell shock, and it was specific to people who had been through war situations. And the name for the disorder changed over time. We recognize at this point that somebody can develop all the symptoms of post-traumatic stress disorder from going through a variety of different kinds of struggles. We know that young children who have not had their needs met for them in some way, or have had something really scary happen when they were very young, even if it doesn't feel to others that it meets a trauma consideration, we recognize that for that young person who has their more limited world, that event may indeed have been a trauma situation and then resulted in the development of these same groups of symptoms that we'll describe in a minute. Somebody else may have been through an assault or a severe car accident or war situations or significant grief or loss. Any of these things might contribute to development of PTSD. In today's age of online resources, what we recognize is that people used to be able to step away from stressful situations. And if they were in a situation that was really stressful at school, then when they came home, that was a more safe environment. So they had more sense of security. They had a home base, a place to feel well. In today's age, because everybody's connected to their technology, if somebody is in a negative situation at school, that situation may very well follow them home through continuing to have bullying occur, perhaps through different media sources. So we feel like children today are at a higher level of potentially having some of these stressors that do come up to a PTSD level, even though in the individual events they may not seem as extreme as that. If you would like to read or explore more on the topic of trauma experiences, whether there's PTSD or not, there's increasing literature on adverse childhood experiences, or ACE, ACE, adverse childhood experiences. And there are even some self-report measures where a person can look through various types of exposures and kind of think about how that might be handled differently for an adult, but be very scary in a child, and therefore have impacted their development differently. Okay. Going on to what is then PTSD. After this exposure or trauma, the person develops a collection of symptoms that becomes very distressing and increases their distress in a day-to-day way. They might experience intrusive recall of the events in the daytime, which are considered flashbacks, or when they're sleeping, called trauma nightmares. And in those intrusive recollections, it's not the same as remembering or kind of reviewing that event happened, but it's as though the person is re-experiencing it in their body. Again, studies have shown that patients who have PTSD, while they are having a flashback or having a nightmare, that their physical body systems are responding as though those stimulus are happening to them at that time. So in the brain, it's as though the trauma is happening again and again and again, and PTSD greatly reinforces itself. the person who's experiencing these recollections or who had the trauma, they're very likely to develop avoidance of things that bring the trauma back to them. So a very common thing is a war veteran who therefore hears a backfire or hears a gunshot and goes straight into a flashback. So the stimulus would be the loud banging sound, and it brought them fully and wholly back to that exposure in their thoughts and into the flashback. So I think that's an idea that a lot of people can relate to. Trauma triggers or stimuli may include smells, taste, music, locations, names, different things, just whatever connects to that person's individual experience. Another response to trauma may include feeling numbed, more disinterested, or more detachment. And that's also protective, because if you are not attached or not engaged in things because you're numb, then you're less likely to be impacted by it. People with PTSD may also experience the same symptoms that we would all experience in a panic attack or an extreme anxiety response, but experiencing it in an ongoing way. So they have high adrenaline all the time, feeling increased arousal, so that's more alert or more agitated, not able to sleep as well. Why would you sleep if you're going to have nightmares? More anger, because anger is a way that you perhaps defend yourself or is a response to feeling out of control. Poor concentration. You're so busy scanning and being aware of what could be harmful to you in the environment that it's hard to focus on tasks. And then easily startled. So that's popping up quickly if somebody comes into the room or calling out if surprised. So this group of symptoms together in somebody who's experienced a trauma can be called PTSD or post-traumatic stress disorder. Okay, sorry, I was checking the next slide. So the treatment of PTSD is, by and large, talk therapy, but medications can also be very helpful, including that it's hard to do talk therapy when flashbacks and nightmares maybe increase or intensify, or the person has an increase if they move from being numbed to being more aroused, just much more agitated. And it's difficult to proceed in treatment when you're feeling hyper aroused and agitated. This is an area where medications might be helpful, either in quelling the symptoms in the moment that are disruptive, or SSRIs, SNRIs are again shown to be helpful in the base treatment of the disorder, not just covering symptoms like an anxiety medication might. And there's data that taking anxiety medications in an ongoing way for PTSD may actually make that disorder worse. So where they might be helpful kind of as rescue medications from time to time, the anxiety medicines tend to induce a feeling of numbing in order to bring down the agitation or the arousal, and in that way they reinforce the illness if used in an ongoing way. So a very refined approach to how to utilize medications may help a person who's previously not been able to do therapeutic work regarding their PTSD to do that work with more success. There are even medications that are shown to be helpful in reducing nightmares and flashbacks specifically, and that has been found helpful for people to then progress in their talk therapy. All right, on to substance abuse and dependence. Someone with an eating disorder is prone to the same abuses as anybody else. And their genetics figure in just like it does for anyone else as well. Some, though, may abuse or misuse substances that are more specific to the eating disorder or serve the eating disorder's purpose. There are so many different varieties in which ways people develop unhealthy coping skills that it'll be impossible to cover them all. But some of the more common things include that the abuse of stimulants, either in diet pills or in energy formulations. Stimulants can cause anxiety and insomnia, rapid heart rate or irregular heart rate, high blood pressure, even at standard dosing or whatever the recommended dose is, or within the content of an energy drink. So sometimes people will not even be intending to use something for a stimulant abusive purpose, but still have a physical response that is unhealthy for them and it feels unsafe to them. If somebody is malnourished and having any kind of medical consequences due to the malnutrition, they may also be much more prone to the negative effects of a stimulant, including the cardiac effects. Fat blockers were more popular 10 and 20 years ago now because there were some new ones that came on the market. And I think a lot of physicians and people in the common populace have recognized that those fat blockers are not a really good idea. There are negative side effects with them. And really importantly, fat blockers can cause malabsorption of vitamins. There are several vitamins that cross from our food into our bodies only when accompanied with fat. So fat blockers can really speed up vitamin depletion. And maybe somebody would think, oh, they're just vitamins, they're not as important. But vitamins are actually really important chemicals within our systems that help various different systems of our bodies run well. And we'll talk more about that in our next talk as well. Alcohol, again, is abused in eating disorders for the same purpose as anybody else might abuse it. Sometimes people will use alcohol intentionally while restricting, or because they've used alcohol, feel like they have to increase their restriction to account for calories. So alcohol can have a different exposure or dynamic within an eating disordered person's distress. Also, if somebody feels disinhibited with alcohol, then they might change their food behaviors during those periods of time. Alcohol also speeds vitamin depletion. There are certain vitamins that if you're having alcohol in your system, your body cannot absorb them as well from the digestive tract. And so somebody who's using alcohol or abusing alcohol who also has an eating disorder is at increased risk of more severe malnutrition. All right, hang in there, we're almost done. Personality disorders. All right. We try not to diagnose personality disorders early on in treatment for anyone. And the reason why is all of us have some personality traits. We tend to be more anxious or more dramatic or more reserved, or, in some way we have personality traits that we know are more specific to us as individuals. So when we're under a lot of stress, we tend to narrow down into our personality traits in a more and more fixed way, and we're not as flexible in our responses to stressors. Once you look at the definition of personality disorders, somebody who's under stress and has backed off into their personal personality trait could look like somebody who has a full-on personality disorder, but it's because they're under stress. Patients who are at a level of needing to come to inpatient hospital for treatment of an eating disorder and that are very likely to have a co-occurring psychiatric disorder are under all sorts of stress. So we want to recognize that the eating disorder itself may utilize this pattern of inflexibility and coping strategies to defend itself within an otherwise healthier supportive environment, such as if parents are trying to support someone or a spouse or a loved one is trying to support someone, the person may use, not intentionally, but through the eating disorder, may use anger or irritability or anxiety or distrust to protect themselves from the positive influence of people trying to help them. And in that way, the eating disorder can be really adaptive and use these person's traits. To be a little bit more clear on a personality trait, I want to mention obsessive compulsive personality disorder, because OCPD, obsessive compulsive personality disorder, is a more commonly identified personality disorder within patients who have eating disorder. There are many personality disorders, there are several of them, so we won't go through all of them, but I'm just going to use this one as an example. In OC traits, so not in the disorder, but just in traits, somebody tends to be more perfectionistic. They tend to worry that if they're not in control of a situation, it may not come out right. So if they're in a group, they want to be the group leader. Or if they're in a group, they may want to kind of keep other people from even doing their tasks, but do it all themselves, because only if they do it themselves do they know that it'll come out right. Somebody with obsessive compulsive traits tends to experience anxiety in a situation that feels outside of their control, and tends to have a high self-imposed need for perfectionism or for things to be just precisely so. For somebody who has those justice traits, not the disorder, and they're in an okay setting where they're used to being at home or school or work, where flexibility comes in is at home, you may express your need for perfectionism in a certain area and say, I'm the only person at my home who's going to deal with this because I just really need it to be just so, but otherwise I can be more flexible. And different things in different relationships. Usually people can be more flexible with their kids, but then recognize that their stressors come up as somebody gets older because they are expecting the older person to be then contributing with their own flexibility. So somebody who's flexible may, if their employer has a concern with them, may respond in a very different way than if their spouse brings a concern to them. That is a flexible personality because you're recognizing what works at home or what works at work won't work in the other situation. So even though it's not my natural way to respond to this situation, I will do things differently. I will be more flexible and I will have a better outcome. Somebody who's greatly under stress or does have obsessive compulsive personality disorder would be more so inflexible. They want to keep responding to the stressor in the same way over and over, even if they're not getting positive results. And it's hard for them to move outside of their comfort zone, their baseline personality structure, in order to adapt to a different situation. To meet criteria for a diagnosis, the person does need to be over 18, but also there's usually evidence of these patterns since adolescence or young adulthood. The treatment for personality disorders is therapy. Medications are not approved for personality disorders. They may be helpful for some specific traits sometimes, but by and large for personality disorders, the treatment is talk therapy. It's working on the person's ability to recognize their very fixed and persistent way of interacting with the world and start in small increments trying out more flexible patterns of interaction because they have this insight now, and seeing whether or not they get success with more flexible patterns, and then the success reinforces that increased flexibility. So that, in very short, very brief, is the therapy for personality disorder. Suicide or self-harm. Obviously, either one of these issues is extremely concerning to loved ones, to healthcare providers, to friends, family, and to the person themselves. As I mentioned earlier, I want to reinforce that people who have major depressive disorder may experience suicidal thinking or self-harm thinking. But then there are people who have suicide or self-harm thinking or actions that don't actually have major depressive disorder. They may have anxiety disorder, they may have a personality disorder, they may have OCD or PTSD, or they may just be in a particular situation that is so overwhelming and so stressful that they can't find any other escape clause. Self-harm and suicide are not the same things. Somebody who uses self-harm is not necessarily working up to a suicidal action. It's definitely reasonable and appropriate to assess somebody who is using self-harm for whether they are also having suicidal thoughts or what the purpose of self-harm was for them at the moment they were distressed and acted. But it's not the same thing as suicide. The overall message includes that if we have concerns, or if you have concerns about somebody's safety or your own safety, it's better to talk about it than to not talk about it. By talking about it, we can determine what we need to do in the moment, in the current environment, to stay safe. And then we can start looking at what are the stressors that are contributing to the hopelessness or the overwhelm, and then start working on those according to which of these things can I change, which of these things can I influence. So suicide cannot be predicted or prevented. That's a statistical thing. Fortunately, so few people complete a suicidal action that we cannot predict who is going to do it. But we know that awareness helps reduce events. We know that call centers help reduce events because they're helping by being present in the moment for somebody who needs them. I also want to mention that in most communities, through the 911 services, there is an ability to identify that there's a psychiatric emergency happening as opposed to a medical emergency, and therefore allows the 911 service to send out somebody who has specific psychiatric skills for assessment and for intervention. And so identifying a psychiatric emergency may help with a better result, as well as for some people, they fear if I call 911, somebody's going to be mad at me because I did that, or it's going to look like a big deal, that neighbors will see, all of that. But by identifying that it's a psychiatric emergency, you can be much more specific about what's going on and try to keep the stimulus of the interaction lower so it doesn't escalate. All right. Oh, I probably just said everything that's on this slide in some way. Well, we'll go through it. So suicidal thoughts can be acute, just in the moment, or they can be chronic, like an ongoing preoccupation with thoughts about death or dying. Some people with chronic suicidal thoughts fall into a pattern of using the suicidal thought to be soothing to them. If they're so overwhelmed and they don't have an escape mechanism, by problem solving the idea of suicide, the person may actually soothe themselves, because what they're doing is they're taking back control of a situation. This is a maladaptive, unhealthy coping strategy, but it may give some insight into not all suicidal thoughts, or not all people who think about suicide go on to act on suicide, because the thought itself may be an unhealthy coping strategy, just the thought, not the action. Self-harm is sometimes self-punishing rather than suicidal in intention. Sometimes it's about communicating distress. Sometimes it's about getting grounded in the moment. Sometimes it's about feeling like they deserve it, different things. So again, a lot of conversation around self-harm to better understand it, and then to figure out how to get that person's emotional needs met without having to resort to the self-harm behavior. And we're almost done. Clinicians work really closely with patients who are having these symptoms and ask a lot of questions so that we can help differentiate through these different things and put plans in place for the person to be safe in their home setting or in their work setting, even while they're still working on the therapeutic actions to heal. All right. I should have taken this slide off, psychiatric medications. It's not my intention to go through this. We've already talked about antidepressants, anti-anxiety medications, which are the anxiolytics. Mood stabilizers are more for bipolar disorder, antipsychotics. I'll probably talk about for just another second here. Sleep aids, the best treatment for poor sleep problems is good sleep hygiene and sleep behaviors. Some sleep aids can be helpful sometimes. And there are some sobriety aids, which are medications that may decrease the person's reward from using substances of abuse. And sometimes that can be also helpful for self-harm or for shoplifting or even in binge and purge. Antipsychotics, I want to briefly mention in the treatment of OCD, which we've talked about being very linked and very similar in the brain pathways to eating disorder for many patients. In OCD treatment, the treatment paradigm is start with an SSRI, which is the selective serotonin reuptake inhibitor. If that's not successful, move up to a high dose SSRI. So find one of the SSRIs that the person tolerates well, but you can move up to a higher dose. And if that's not successful, augment possibly with an atypical antipsychotic. That is a class of medication, atypical antipsychotics. So in the context of malnutrition or active eating disorder behaviors, the first two levels of care, which are antidepressant based, are undercut by the malnutrition. The malnutrition actually makes them less effective. So the next level of care after that is the atypical antipsychotics. And that's really interesting because we do not have medications that are approved for the treatment of anorexia nervosa. Bulimia nervosa has one medication, which is Prozac, and that's really old data. But there have been so many studies looking at what medication can we use to treat an eating disorder, and we just don't have that amongst the SSRIs or the mood stabilizers. But interestingly, there are 3 antipsychotic medications that are shown to be helpful in reducing the extremely ruminative, anxious thoughts that somebody with OCD or with eating disorder may be experiencing in their illness. And that may be a consideration for you or for your loved one. All right. On-label versus off-label. On-label means that there's an FDA indication for using this medicine for this reason. Off-label means that there's not an FDA-approved indication to use this medication for this illness, but because it is a medication that has an on-label use, that means the FDA has assessed it for dosing strategies, for its safety, for its side effects, for interactions. So there's a lot more safety using an FDA-approved medication, and then sometimes we will use them off-label because since they've been developed and used, clinicians have developed an awareness of them being helpful for things that haven't been studied at the level required for an FDA approval. If your provider is ever recommending an off-label use of a medication, they should be able to explain to you why they feel like that medication is going to be helpful and why they're recommending it for you, as well as side effects and things just like otherwise an informed consent. Why do antidepressants take so long? They are classed, like we talked about earlier, for their site of action. So an SSRI, a selective serotonin reuptake inhibitor, they're helping your brain's serotonin stay out longer where it signals more and kind of tricks the brain into thinking there's more serotonin than there is. But if that was it, if that's all that was needed, you would have an immediate response to the antidepressant medication. Instead, we know it's 4 to 6 weeks to get to a full effect. Usually people have side effects more in the first 2 to 3 weeks, and then their benefit isn't until they're on their first refill 4 to 6 weeks later, which sometimes makes it hard for people to stay on their medications. The reason for that is that there are multiple pathways that have to get triggered one after another as a chain reaction to get to that full effect. And as I mentioned earlier, antidepressants work best in a nourished body. Proteins that we eat are the building blocks of neurochemicals, and then vitamins may help transition some of those proteins into what they need to become the neurochemicals that we need. So we need a nourished body for medications to be optimal. The black box warning. In 2004, a black box warning came out on all antidepressant medications that they may increase the risk of suicidal thinking when initiating treatment with an antidepressant, especially in people aged 24 and younger. That was based off of one specific study that showed an increased risk up to age 24 from the baseline risk being 0.5 to 1%, and the risk increased to 1 to 2%. Still a very low risk, but an increase in the risk. Ages 24 to 65, the risk was neutral. It wasn't increased or decreased. Age 65, the risk was decreased. However, when this black box warning came out that medications might increase the risk, the prescription of the medications fell greatly, and every year since then we've had an increase in actual suicides in this country because we recognize that people in that age group and maybe in other age groups are electing not to take medications even though they're indicated because they're concerned about this black box warning. So we are recognizing that the black box warning, which was intended to say, use with caution, please monitor more closely when you're initiating treatment with these medications, didn't mean don't use these, because not using them and not treating depression or other psychiatric illnesses increases risk more than any risk associated with the medication. All right, that's the end of this